Hello everyone. Today we will be going through 20 PYQs from the topic of CVS from the subject of pediatrics. Which of the following manifestations of rheumatic fever disappears completely? We all know that carditis and its complications or sequelae, they stay. MR, MS, right? Atrial stenosis. These are the complications or sequelae following carditis in rheumatic fever. Chorea requires treatment following rheumatic fever episode. Arthritis, migratory polyarthritis disappears completely after the acute episode. So this is the right option. Next question is coarctation of aorta is associated commonly with, your options are Klinefelter syndrome, Down syndrome, Turner syndrome and Noonan syndrome. Coarctation is associated commonly with Turner syndrome. We all know this. Which of the following heart diseases do not present with congestive cardiac failure? Your options are PDA, Tetralogy of Fallot, ventricular septal defect and pulmonary stenosis. So PDA and ventricular septal defect, if the defect is large left to right shunt, so these are two known causes of CCF. Pulmonary stenosis, if the stenosis is severe, it can lead to right-sided heart failure. Tetralogy of Fallot has VSD as a component, and VSD, the large VSD, it equalizes pressure in both the ventricles. So tetralogy of Fallot does not present with CCF. The answer to this question is TOF does not present with CCF. The components of tetralogy of Fallot are all except pulmonary stenosis. Yes, pulmonary infundibular stenosis is there. Right ventricular hypertrophy, it is there. Atrial septal defect, no. When atrial septal defect is there with other four components of tetralogy of Fallot, that is called pentalogy. So atrial septal defect is not a component of TOF. Ventricular septal defect is a component of TOF. So here the answer is atrial septal defect. In a premature infant, patent ductus arteriosus can be kept open by administration of, so prostaglandin analogs, prostaglandin inhibitors, PGE1 or none of the above. So if the infant's heart disease is such that keeping the ductus arteriosus open will help in ventilating the child and will help in treating the child until surgery. So we'll have to keep it open using PGE1. PGE1, what is the generic name of PGE1? That is alprostadil, right? Alprostadil is the generic name of PGE1 and that is used in premature infants to keep the ductus arteriosus open. Systemic hypertension is a feature of, what are the options? Hypothyroidism, congenital adrenal hyperplasia, acute or chronic glomerulonephritis and nephrotic syndrome. So nephrotic syndrome does not present with systemic hypertension. It may present with hypotension because of third spacing and fluid extravasation. CAH, classic CAH, salt losing CAH presents with hypotension. Systemic hypertension is not always a feature. Again, hypothyroidism also directly, there is no reason to have systemic hypertension. Acute or chronic glomerulonephritis, systemic hypertension may be a feature because of renal parenchymal involvement, right? A newborn presents with deepening cyanosis at birth with CCF and normal first heart sound. X-ray reveals cardiomegaly. Okay, diagnosis is, now here your clues are, there is cyanosis at birth, okay, and there is CCF, the first heart sound is normal and X-ray reveals cardiomegaly. Now your options are TOF, Epstein anomaly, TGA and tricuspid atresia. Cyanosis at birth and cardiomegaly, these two things are not seen in TOF. Okay, TOF usually doesn't present with cardiomegaly on the X-ray and there is no cyanosis at birth. So this option is out, plus you won't see CCF in TOF. So that rules out TOF as a problem in this question. Epstein anomaly and tricuspid atresia. Now you have seen here that the first heart sound is normal. In Epstein anomaly and in tricuspid atresia, the S1 is going to be loud in both. The S1 is going to be loud in tricuspid atresia as well as Epstein anomaly, and it will be split also in Epstein anomaly. It won't be normal. So again these two options are ruled out. Cardiomegaly, look at the third option, TGA, cyanosis at birth, CCF, normal first heart sound, cardiomegaly on the X-ray. Okay, due to transposition of great arteries. Here this is the correct answer in this question. And what is the X-ray finding in TGA? Comment in the comment section below. What is the X-ray finding you see in transposition of great arteries? So you definitely see cardiomegaly there, and you see cyanosis in the newborn period. That those two clues point towards TGA as the answer to this question. Pulmonary plethora is not seen in, your options are ASD, PDA, VSD and Tetralogy of Fallot. Now here plethora means increased blood flow. So pulmonary increased blood flow to the lungs is seen in left to right shunts. ASD, PDA, VSD all are left to right shunts. So pulmonary plethora is seen in this. Tetralogy of Fallot is associated with pulmonary infundibular stenosis, and that is associated with oligemic lung fields, right? Oligemic lung fields, and pulmonary plethora is not seen in Tetralogy of Fallot. Eisenmenger complex is seen in all except PDA, VSD, ASD and TAPVC. So Eisenmenger complex is seen in all except. Now there is literature that Eisenmenger complex is seen in left to right shunts, simple left to right shunts, long standing large left to right shunts leading to large amounts of blood flow to the lungs through the defect. So Eisenmenger complex is seen in PDA, VSD, rarely it may also be seen in long standing ASD. TAPVC also there is some literature that it may have Eisenmenger complex or Eisenmengerization, but it is very rare. So in all, among all the four options that are given, Eisenmenger complex is seen in all except TAPVC. Your answer should be TAPVC. It is seen, but it is very rare. Left to right shunt, simple left to right shunts, which is PDA, VSD and ASD, Eisenmengerization is seen in long standing untreated cases. Carey-Comb's murmur is seen in pulmonary hypertension, acute rheumatic carditis, tetralogy of Fallot and aortic regurgitation. So Carey-Comb's murmur is seen in acute rheumatic carditis. It is basically a mid-diastolic murmur, and that occurs due to acute mitral regurgitation, that is also during the rheumatic carditis phase, involvement of the mitral valve, right? So it's a mid-diastolic murmur that you see in acute rheumatic carditis. Pure left-sided heart failure may be seen in ASD, aortic stenosis, PDA and pulmonary valvular obstruction. So pure left-sided heart failure. Now PDA, ASD, aortic stenosis and pulmonary valvular obstruction are your options. PDA can lead to CCF. It can lead to both right as well as left ventricular failure. Pulmonary valvular obstruction, it is a right sided heart failure. PDA is usually both. The baby may have features of both sided heart failure. ASD usually does not present with heart failure. Sometimes it's an incidental finding as well. Aortic stenosis presents with pure left sided heart failure. So here your answer is aortic stenosis. A child with TOF uses which of the following positions? Supine, prone, squatting and leaning forward. Here the answer is squatting. What happens when a child with TOF squats? Why the oxygenation improves? Oxygenation improves because there is increase in systemic vascular resistance, and therefore right to left shunting reduces and there is improved blood flow to the lungs. So a child with TOF uses which of the following positions? The answer is squatting. Pulsatile varicose veins in lower limbs is seen in, okay, here is a picture of lower limb varicose veins. Your options are Klippel-Trenaunay syndrome, tricuspid regurgitation, right ventricular failure, and tricuspid stenosis. Among these, varicose veins, okay, due to venous lymphatic malformations. Varicose veins are a feature of Klippel-Trenaunay syndrome. They are very rarely seen in tricuspid regurgitation and RV failure, and they are not seen in tricuspid stenosis. So here in these two they are seen very rarely, and in stenosis it's not seen. So your answer is Klippel-Trenaunay syndrome because it's a typical feature of that syndrome. Loud S1 in mitral stenosis is seen in, your options are A, prolonged flow through mitral valve, B, first degree heart block, C, calcification of the valve, and D, immobilization of the valve. Now loud S1 in mitral stenosis is seen in, what are the options? Among these options, first degree heart block is no, it's not the option. Calcification and immobilization of the valve, no, again these two are not the option. The reason why the mitral stenosis condition has loud S1, the reason is that the mitral valve is still pliable and it remains open for a longer time till the onset of isovolumetric contraction of the both the ventricles, right, and also because of the elevated left atrial pressure. So loud S1 in mitral stenosis is seen in prolonged flow through the mitral valve and also because of elevated left atrial pressure, right, and the mitral valve remains open at the onset of isovolumetric contractions of both the ventricles. So your answer here is prolonged flow through mitral valve. That's why the S1 is loud in MS. Cardiomyopathy is a feature of all except DMD, Friedreich's ataxia, Pompe disease, and Lowy syndrome. Now DMD, yes, it has cardiomyopathy, and what kind of dilated cardiomyopathy is seen in DMD. Friedreich's ataxia and Pompe, both of these will show hypertrophic type of cardiomyopathy. Lowy syndrome is typically not associated with cardiomyopathy. What is it? It is oculocerebrorenal syndrome, right? Oculocerebrorenal syndrome. This is Lowy syndrome. So oculo, what all is there? There is cataract and there is glaucoma. Cerebro, what are the brain involvements? They may present with developmental delay, they may present with hypotonia, right? Renal, they present with Fanconi syndrome, right? Renal, they present with Fanconi syndrome. So cardiomyopathy is not a typical feature of Lowy syndrome, whereas it is a feature in all the other three. What is true about subcutaneous nodules in rheumatic fever? They are non-tender. They occur in 50% of patients of acute rheumatic fever. They present on the abdomen or they are associated with arthritis. They occur in 50% patients? No, they occur only in 10 to 20% of patients with acute rheumatic fever. So they are relatively rare. Present on the abdomen? No. They are usually present on extensor surfaces like elbows and shins of tibia, right? So extensor surfaces, they may be present on spine and scalp. They are not present typically on the abdomen. They are associated with arthritis? No, they are typically associated with carditis. You see someone with acute rheumatic fever, clinically there's a suspicion of acute rheumatic fever. You notice they have subcutaneous nodules, you have to screen the heart because it is highly associated with carditis. They are non-tender, yes, this is the right answer. This is true about subcutaneous nodules. They are non-tender nodules and they are seen in rheumatic fever. Native valve endocarditis, most common cause is Staphylococcus aureus for native valve endocarditis. We all know this. Infective endocarditis is not seen in VSD, ASD, TOF and MR. We all know MR, mitral regurgitation, tetralogy of Fallot, VSD, they all can have infective endocarditis. But it is not a feature of ASD typically, okay, because of the low velocity and turbulence of blood through the ASD. So infective endocarditis is not a typical feature of ASD. It is not seen in ASD, whereas it is seen in all the other three options. True about rheumatic carditis is endocarditis, myocarditis, pericarditis, and pancarditis. The answer is pancarditis. It can involve all the layers of the heart. Rheumatic carditis can involve all layers of the heart. Congestive cardiac failure may be clinically diagnosed in an infant with. Your options are palpable liver, pedal edema, elevated JVP, and liver enlargement. So now here, read the question carefully. It mentions infant. Congestive cardiac failure may be clinically diagnosed in an infant. Palpable liver may be palpable in an infant even in cases of bronchiolitis, and even normally sometimes just palpable liver actually does not mean there is liver enlargement. Pedal edema, no. Dependent parts edema that is usually seen in older children. It's not exactly a feature of infants. Elevated JVP, practically you will not see this in infants because of short neck, subcutaneous fat. They won't be cooperative to assess the JVP in the typical position, right? So you won't see this. Now among palpable liver and liver enlargement, palpable liver doesn't mean anything until you actually check the liver span. So liver span for that age, that is what you need to check. And if there is enlargement, that is if liver span is more than the normal liver span for that age, okay, then that indicates liver enlargement. And if there are other symptoms and history pointing towards congestive cardiac failure, and you have a finding of liver enlargement on clinical examination, that way you can diagnose CCF in an infant, provided the history and other clinical examination also supports the diagnosis. I hope these 20 questions were useful for you, and stay subscribed for more such videos.